Well, good afternoon, everybody. It's SEVA VentRounds Express, and today we're going to focus on cycle synchrony. Today's number questions. This is a learning sessions for all of us. So, some key items for you to be aware of is what we call the key knowledge to know. And the first one is the word trigger and cycle. These have been used through the literature in different ways, and those different ways to use them sometimes cause confusion in what we call one thing, and you may be referring to one thing, and I'm understanding another one. So it's good for us to essentially establish what each one means. And trigger means the start of mechanical inspiration. Trigger can be started by the patient, or it can be started by the ventilator or the machine. So meaning started by the time, so you set a respiratory rate, or it can be triggered by the patient or a signal from the patient. And then cycle is the end of mechanical inspiration. So meaning the end of the inspiratory phase cycles off and expiration starts. And this, again, in the literature, you may find the term cycle used as trigger, but for us and the way that we have defined it, it's trigger and cycle. Rob, any comments?
Nope, that's good.
The second key knowledge is you need to remember that whenever we're talking about the classifying synchrony, the patient is the reference signal. Now we have enough technology that we can capture the neural signal from the patient, and for that we use electrical activity of the diaphragm with a catheter. We also can obtain the signal from the patient from the muscle pressure generated by the patient, and for that we use an esophageal catheter. And finally, if we don't have any of these three, we can use an airway signal, and that's what usually we do. We have on all the patients that you can see at the airway signals, either on pressure or on the flow, to understand what is the to recognize the presence of muscle activity. You will also notice in this graph that you have here that the electrical activity of the diaphragm started first, followed by the esophageal pressure, and followed by the airway changes. And so there's always going to be a little bit of a lag between the neural signal, and the airway signal. And there may also be, in certain circumstances, a presence of an electric signal with not the same magnitude or length of duration of the esophageal or the muscle signal. And that's a little bit more complicated, but just to make you aware that this is called neuromechanical uncoupling, meaning that the signal from the brain and the signal from the muscle are not matching. All right. So let's get started. And this is our first signal. This one is courtesy of Ariel Garnero, so I put here. And he gave us this graph. So it's there for you, and we're always go in order. So the first thing is to define what is the tag, followed by the load, followed by going in order, trigger, inspiration, cycle, and expiration. So give it a try and start putting in the chat. And what I would recommend is that you put first the tag, then just press enter and send it, and then enter your load, enter, and then just keep going at it without fear. I'm gonna give you a minute or so to read this waveform. Okay, tags are starting to come in. Very good. So I'm seeing some of the data that is coming in. All of you are recognizing initially as a pressure control, meaning that the pressure is being controlled. And we know that because actually, if you look at the flow, so remember when you're controlling pressure, I always start by looking at the flow. That helps me recognize the mode faster. Well, you can see rapidly that the flow between each one of these curves is very different amongst them. And the inspiratory times are also pretty different. So this essentially tells me that this patient has what we would call pressure control. So we're controlling the pressure, even though it doesn't look like a perfect, beautiful square that you would expect. That has to do with other features that we're going to talk in a second. But you would expect it to look like that square that I just drew on that one, and it doesn't, because there's PMOS and the ventilators are not very good at controlling pressure as they as theory would. So that's a pressure control breath. And then you guys have put CSV, meaning you recognize that this is a continuous spontaneous ventilation breath sequence. And by that, we mean that every single breath that we see here, you can see that it's triggered by the patient. And we know that because not only there's this deflection in the pressure waveform, but there's also in this ventilator in particular, it tells you that that's the case by changing the color on the on whatever the variable is triggering. In this case is pressure. So you see every breath on this sequence was pressure triggered. And then we know it's cycled, and there's a couple of guides here to tell you that it's cycled by the patient. The first one is that the I time is very different between them, between each one of those. And so for each one of them, it's different, the I time, which tells you that it's not being controlled, and it's most likely controlled by a flow cycling criteria termination, so percent of the peak flow. So both are being triggered and cycled by the patient. And finally, the targeting scheme, which we have reviewed, we know that for all of them, yeah, we don't see any change on the pressure. We don't see any other one. And just knowing and using the app that Rob developed with all the taxonomy, knowing your ventilator, this is essentially set point. So there's no other hidden stuff. It's what you set, the PEEP, the pressure support, and the flow termination criteria and target and trigger criteria, and that's it. In terms of what is the load, I see most of you have put PMOS, the presence of PMOS as the presence of what's happening. And actually during inspiration, there's no doubt about it. There's instead of looking that exponential decay, all of them look sinusoidal. So this is all the presence of PMOS, which is not a load, but it hides the load, the elastic or resistive load. And then during expiration, actually, this is a nice expiration. It looks passive. In this one, this looks also relatively passive and passive here. There's some PMOS here. And that tells me probably it's returning to baseline relatively fast, less than a second. So I would say that this is most likely elastic load, just based on what I'm seeing there. And there's other hints that can help you look at that. I mean, so this patient is doing effort, fair amount of effort to inflate the lungs. They're getting 18 above PEEP and generating 448. So with around 20, 448 divided by 20 gives you the compliance of this patient, and you will realize that it's on the lower side. So elastic also goes there, and plus all the effort that the patient is doing. Then in terms of trigger, a good amount of you talk about the trigger, about it being late. So this is a very nice waveform because it has, when they did this graph, they left, the patient had a catheter inside, esophageal monitoring catheter. And so in the bottom, this over here is the electrical activity of the diaphragm. And so you can see the electrical activity of the diaphragm. And as I said, this is the gold standard in this case. This tells you what it is. But what I like about this graph that Ariel provided is that it gives you the correlation with the flow waveform. And you can see how by looking at the waveform, you can make a decision of where the PMOS was occurring. Now, look at the different waveforms, and it's very interesting. So the first one, they overlaid the EDI on top of the pressure waveform. So you can see that the electrical activity started here for this patient, and it took a while for the patient to actually deform the pressure waveform. So the electrical activity started way behind, and it didn't trigger the bend until a while. Although I can see that it crossed the flow, the zero baseline earlier. So this may have to do with how this was set. But you can see on the next one, it's actually pretty well timed as the pressure, the PMOS starts increasing, the P bend starts going down. Here, it's pretty synchronous. I mean, it's essentially, it seems that the patient did more effort and was able to activate to trigger the ventilator right on time, and the same with this one. So this one and this one look beautiful. This one looks like a late trigger, and this one is definitely a late trigger now that we have the EDI. So you have a couple of late triggers, so breath number 2 and number 3, and then 2 breaths that are completely normal, this one and this one, which would be 4 and 5. Rob, comments about trigger?
No, but on the top graph, the yellow line is airway pressure as it
Yes.
stands, and the looks like a white line on top of that. Isn't that the airway pressure you'd get if NAVA was working?
That's the EDI superimposed.
Are you sure it's the EDI and it's not the airway pressure that you would get with NAVA?
Well, it would be, but it
that's
comes
what
from
it
the
is.
EDI, right?
Yeah, it's just an amplification of the EDI, so it's not exactly the same signal. So you can see it, if you can just look down, you can see it's not the same shape as the EDI, but it's very similar.
Yes, because it's adjusted for. So I mean, but let's just coordinate on this. Would you agree that if the shape is proportional to the shape down below,
Yep.
and the start starts at the same time as this signal down below? Would that be correct?
That's correct. It's just that it's simulated pressure. It's not actually
Fair
EDI
enough.
signal.
So
So
Eduardo,
that's a good point. Yeah, go ahead.
this is Ren. That line is the pressure that you would get with whatever NAVA level was left in the machine when you put the EDI catheter in.
Perfect.
Thanks, Rand.
And so, so we do agree that because it's overlaid, this is a manifestation of the EDI when the neural signal started, correct?
Right.
Yeah, absolutely.
Yes. Okay. All righty. So we agree with the normal and the late, and for everybody, this is the estimated pressure from the EDI. All righty. Now, during inspiration, many of you recognized the work shifting. So there's some degree of work shifting, and what that means is the effort. And I'm using this again. Although it's the pressure, I'm using it as the EDI. There was activity, and we should have been pressurizing the system during that period of time. So I'm just going to highlight here the area of discrepancy between these two, which is area in which there was work by the patient, but there was no response of pressure by the ventilator. Rob, would you agree that that's a representation of work shifting?
Yeah.
And so you can see very little work shifting on this one. This was a very nicely, it matches very nicely the representation of the effort by the patient. This one very poorly, or there's a delay on how the ventilator is responding to the patient. However, you could say that for not having an EDI, it's pretty darn close to the patient. So maybe a little bit more support would have dealt with that. But this is an illustrative case. So I would say that there's some work shifting. It's not terrible, but there's some. And then in terms of cycle, which is when the breath ends, the peak of this, and let me erase the graph for now. And I'm using this pressure waveform that it's as Rob and Ren highlighted. This waveform as the timing of the EDI. That's how I'm using it. So you can see that the peak ends over here, and by convention, the NAVA team decided that it was around 70%. So this ends pretty synchronous, and you can see that there is no change in the flow there. So the flow crosses baseline really rapidly, and there's no pause or anything. So this is a good cycle. This one over here, actually, you have this little dimple, and actually you can see it a little bit better on this one. That dimple, that as the patient still had activity, and you can see here how the patient was still having activation of the inspiratory muscles, and that's what gives you this what we would call late cycle. Early cycle. So the patient cycled off, but the diaphragm was still doing effort, and it cycled off, and you have this late cycle. Rob?
It's all good.
Ren?
Yeah, I agree.
Alrighty. So yeah, and I like this graph in particular, and then during expiration is basically normal. I like this graph a lot because it shows you how challenging it can be to achieve synchrony on some of these patients, right? So there's always going to be some delay or in the signal and how the ventilator responds. And you technically, if you were grading these, you would grade a lot of these interactions as either delays, earlys or late in terms of synchrony, and they may not be clinically relevant. They may be. There may not be. I'm not sure. But this was pretty close in terms of synchrony. Actually, when I was looking at the waveform, I said, oh, that's pretty close. That was my feeling. Thoughts, Rob?
Yeah, there's another indication of the patient's inspiratory effort, and that's the EDI peak down at the bottom right. 25 is a pretty high number. I think normal breathing is single digits, like between 5 and 10 if you have normal lungs and normal unassisted breathing. So that shows a high. It's sort of like, I think you would think of it as like a occlusion pressure, PO1 or something like that. It's the intensity of the patient's effort, but it doesn't necessarily translate into work shifting unless the patient can move some gas.
Very good. Ren, you being our in-house NAVA driver, any thoughts on this?
Yeah, that's scary. Yeah, actually, I agree with Rob. Probably a quote unquote normal EDI is usually about 11. So 25. I mean, like Rob said, you can't really correlate that with anything specific, but it tends to go up as respiratory mechanics worsen. So I think that is an indication that all is not well.
Very good. Excellent. So a good amount of learning on this slide regarding triggering and cycling, and then reviewing the EDI signal that we have available. Thank you. I'm looking for any other comments. I don't see others. Okay. If you have any questions, comments, just unmute. And again, if you see something that doesn't make sense, say it, because we're all learning here. Thank you.
So Eduardo, can I just so on that patient, did they actually try NAVA, or had they finished using NAVA? Is that why the EDI catheter was in place?
I would not be able to say this. This was it's from Ariel may be able to comment on that.
And the reason I ask, and maybe Ariel can comment, is you know, this level of, and as you said, this isn't severe dysynchrony, but this level of dysynchrony could be seen in NAVA if you had the EDI trigger set inappropriately. I mean, you could still see you know, late triggering and things like that if you set the EDI threshold too high.
Yeah,
you still have to kind of watch that, even though NAVA is a wonderful synchrony mode.
Eduardo, NAVA was being used before. I always manipulate these images my idea was to show the differences between mechanical inspiratory time and neural inspiratory time. As you can see up there, the catheter position was kind of questioned at that time, but the only reason we have these graphics is because I wanted to make it educational for all of you. The only thing I can have to say is, like, we have pressure support, and overlay the EDI. I don't know if we can compare the tracing of the EDI because at that time it's not assisting the patient with pressure support. So I was thinking that maybe the work shifting should be done versus a perfect square graphic on pressure support. I wouldn't take the EDI as a reference at that point.
Yeah, fair point. So uh, I see what you're saying. So you're saying, okay, that it should look like this, and all of that area is area that it's not being supported.
No, I don't think that's true.
Okay.
If that white line is the simulated NAVA pressure, that's going to always be proportional to the EDI signal. It's NAVA pressure waveform is not square. It's whatever the EDI signal says it is.
Rob, but since NAVA wasn't working at the time, there's no gain. The gain was 0, so that's pure EDI signal.
Yeah, but the point here, Ariel, is that what when you talk about work shifting is you're trying to how much is the patient doing and how much the ventilator is doing. So here the patient would have been doing this amount, and instead of that, it was below baseline throughout this amount. This is a more complex thought, so we're gonna have to think a little bit more about this and get back to it, Ariel. Sounds fair?
Perfect.
All right. So I'm gonna show since we talked a little bit. This is a patient without EDI, and let's take a look at it for a second. So go ahead and write your thoughts on the tag, the load, and what's the PV discordance. Just have no fear. The more signals we have, the more challenging it becomes to start reading these waveforms. That's a true statement, but because you start seeing all these little details that you didn't see before. So in that sense, ignorance was bliss. Alrighty, so I see a couple of you answered that this was pressure control, and indeed it's pressure control. You can see the flow, how the flow is not controlled at all. It's different in each one of the breaths. In terms of the breath sequence, you recognize appropriately that this is CMB, at least on this breath sequence that we're seeing here, and also by looking at the mode that it's highlighted down here in this ventilator. This is a Puritan Bennett 840. And we know that this is CMB because of the following. Every breath is triggered by the patient, and we know that just by looking at this waveform, by looking at the depression, the drop in the pressure in each one of the breaths during inspiration, and you can see that good amount of drop on the pressure. So it's patient triggered, but we know it's patient cycled, and the key here to know that this is patient cycled is you will realize, and I'm gonna just jump ahead to the cycle, is that the breath actually goes beyond the baseline. It goes beyond the baseline over here, and over here. And if you match, I don't know why those circles keep appearing. If you match that with the pressure, there's still pressure going into this patient during that period that the flow is going. So during inspiration, the patient is actually now exhaling all this area that I shaded in red very poorly because my cursor was failing miserably. And so that's a telltale sign that the ventilator is controlling the inspiratory time. And so because it's controlling the inspiratory time, the patient said, I want to exhale. And so the patient exhaled against the ventilator, giving the pressure, and actually was exhaling during inspiration. So that tells you that this is a mandatory breath because the cycle is controlled by the machine. And finally, its set point. We know that from this ventilator because we set the inspiratory time, the inspiratory pressure too. The load during inspiration and expiration is PMOS, as Mike recognized. And we know that because it doesn't have that exponential decay in either or. And so all this area over here that I'm shading is PMOS for this patient. In terms of trigger, I think that the trigger looks relatively normal, I would say. Sorry, I was going to erase everything. Erase all ink. And so in terms of trigger, it seems to, I mean, these drops in pressure tells me that the patient was probably doing effort, and you can see that the patient was switching from exhalation to inspiration, and that dropped the pressure somewhat. So there may be a little bit of late, but it's just sometimes you will see those drops with very high effort, even though the ventilator is responding as fast as it can. During inspiration, we talked there's some work shifting, although the pressure is not dropping below baseline, but the patient is doing more work during inspiration. And then during the cycling is late, as we pointed out here, the patient is exhaling during inspiration. Now, some ventilators don't let you exhale until you reach certain threshold. This one lets you exhale if you want. Some of them, what you will see is a little pause here. It looks like a inspiratory pause, and then the patient would exhale. And so that's a marker. If you see that that ventilator is essentially only lets you exhale if you surpass certain amount of pressure. And then during expiration, evidently there's expiratory work, as we pointed out. Comments, Rob?
Yeah, getting back to what you were showing, how the patient can actually exhale before the ventilator cycles inspiration off. That's due to what they call an active exhalation valve. Some ventilators have it, some don't. Some modes have it on some ventilators and other modes don't. And this is a situation where on this particular ventilator, the ventilator will display an inaccurate tidal volume because it doesn't, because it subtracts out that negative volume. The area between that you've covered, colored in red, that is to the ventilator, that's negative volume. So it subtracts that off of the positive area, which is the peak of that tidal volume is the tidal volume. So you're not displaying the tidal volume waveform, but that should be the peak of that thing, and it's not calculated that way. I'll put in a paper that describes all that. It's a problem with some ventilators.
Yeah, so the ventilator is going to display the area that it's here like squares.
Yeah.
And tell you that that's what the patient inhaled. But it actually includes, this part should be included, and it's not being included. Is that what you're saying, Rob?
Exactly.
Very good. With that, we finish today's SEVA VentRounds, 2:30 on the dot. Please join us in a couple of weeks. We're going to be focusing on work shifting next week, in a couple of weeks, now that we have done trigger and cycle synchrony. So we're going to get into work shifting. And so just the topic that Ariel raised, and it's going to be, I'm sure, filled with thought process. Now, for the fellows on the line, I'll meet you in G61 to do live bedside rounds. Actually, we have a patient on PAV, so see you there. Thank you.